It's slightly an unusual topic for a radiation oncologist talking about PARP inhibitors in metastatic prostate cancer. But let me see what justice I can do to it. Uh, as an introduction, PARP is actually an enzyme. It is poly ADP ribosyl polymerase. It's a polymerase enzyme that is involved in the DNA repair mechanism. This enzyme actually catabolizes ADP ribose, and PARP also repairs the damage. Sorry, repairs the damage caused by DNA damage like aging, radiation, etc. It's a very rate limiting step, so that is why inhibition of this enzyme could actually lead on to instability and leading on to cell death. So how are we going to use this in attacking prostate cancer? We'll be seeing today. Okay, so this is a nice slide that actually shows us that after a single strand break on a HRR, which is homologous recombination repair competent cells, which is a normal cell, we would not be requiring any blockage of this PARP inhibition. Whereas in a cell which is HRR competent again, DNA would still get repaired. That is, the DNA would still go on and have survival. But then, in a patient who has got HRD, which is homologous recombination deficient cell, which is probably a cancer cell from a patient who has got genetic abnormality, adding on this PARP inhibition could lead on to a unrepaired double strand break and induce something called as a synthetic lethality and leading on to cell death. So this molecule, the PARP inhibitors have actually shown the benefit in ovarian cancer and at times in breast cancer. Now we are going to see how it is going to be useful in prostate cancer. So there are several DNA repair pathways that can lead on to genetic instability and drive tumor growth. Okay, so we know many of these genes that when mutated can lead on to tumor growth. So those are the HRR, that is the homologous recombination repair genes, namely ATM, BRCA1 and 2, PALB2, CHEK1 and 2, and RAD51. Pretty much in this entire slide, we are going to look at these mutations only and the benefits if a patient with prostate cancer actually harbors one of these mutations. So HRR is a key mechanism for repair of the double-stranded DNA breaks. So if these are mutated, that break won't be possible, repair won't be possible. Okay, so among these genes, there are two types of genes called one of the sensors of the double strand break, which is the ATM, CHEK2, etc. So you should remember that ATM and CHEK2, which we saw earlier, are actually sensors, whereas the effectors of the HRR are BRCA1 and 2 and PALB2, RAD51. So in fact, RAD51 is slightly less important, but PALB2 and BRCA1 and 2 are more important effectors of HRR. Okay, so the DNA repair gene aberrations are enriched in certain patients, and in a CRPC, we could actually target the patients who have such mutations. We should also know that presence of these mutations, the BRCA and AT mutation, actually increases the risk of death by about 20-fold. So somebody who has got this tendency to have a mutation are actually going to die or probably going to develop a castration-resistant prostate cancer much higher than those who do not harbor. But in spite of all this, you still see that the number of patients who have these germline mutations or somatic mutations are actually far and few. 73% don't harbor, only about 23%, 27% would roughly harbor such a mutation. Okay, of which BRCA2 is the most frequently occurring mutation. Well, you have been seeing that these slides are all actually we have copied out from one or two other presentation only. So this is a disclaimer. 70% of the slides are cut copy and only 30% are original. And in all, certainly I have not treated anyone with olaparib, and probably in many of our medoncs have also not treated. All experience I have is having radiated one patient who was on olaparib. Well, now let's go on to see the NCCN guidelines, which recommends testing for such a HRR mutation only. So if we actually see ESMO guidelines released in 2015 or ESMO to EAU 2017 do not currently recommend such testing at all. But then in a patient who has got metastatic disease and who has a high burden of disease and who could possibly jump into the CRPC soon, we should probably be considering testing for these HRR mutations and MSI and MSI testing also. Okay, what do we use? Whether do we use blood or tissue for somatic or genetic testing? Excuse me, just a moment. Okay, so which sample are we going to use? We should know that blood testing may apparently miss about 50% of those harboring HRR mutations. So a tissue would actually be useful to detect both somatic and germline mutations. Tissue testing may not differentiate the genetic versus non-genetic nature, but then after doing a tissue testing, we might still have to put that patient to see if the patient has a genetic predisposition or not to help the future generations. Okay, so the current testing practice is generally like this. Most people generally resort to blood testing, which is commonly performed, or later on use the tissues. Very rarely, we could also be using circulating tumor cell DNA or circulating tumor cells also, which is less commonly performed. Okay, this is a dark slide, but this is a very relevant slide for somebody who doesn't use the genetic testing on a regular basis. So anybody who has a metastatic CRPC at diagnosis or there is a disease progression, we could probably be first using their tissue to test. If the tissue is not available or it's too old or fixed very long time back, then we should probably be considering a rebiopsy. If a rebiopsy is done and a fresh frozen sample is sent and the mutation is actually found, only then that patient has to be sent for germline testing counseling. If the patient has already been found to have a somatic mutation, we could probably be initiating therapy as it is appropriate. Probably in our case, start off on a PARP inhibitor if appropriate. Okay, so what are the trials that we would be seeing for PARP inhibitor usage? The Triton trials, which have used the rucaparib, which is one of the FDA-approved PARP inhibitor. And the other one is olaparib, which is much more commonly used. This is the olaparib, which has again been proven on a phase 3 trial and has been approved for use in prostate metastatic CRPC. And the other trials are TOPARP, which again has used another molecule called as topaparib. Yes. So let us go on to see a little more details about this PROFOUND trial. This is a first randomized phase 3 trial, which looked at the efficacy of olaparib versus other non-hormonal agents like enzalutamide or abiraterone weighed against olaparib. So anybody who has a qualifying HRR mutation on a tumor tissue is eligible. Investigator assessed progression has to be recorded on a radiological basis and a good performance status has to be there. No prior treatment with any DNA cytotoxic agents is one of the criteria. So DNA damaging agents are platinum probably in case of prostate should not be used. So PARP inhibitors is only for those who have actually gone through DOSI or cabazitaxel, but not any platinum based therapy. So there are two cohorts. One is the HRR arm with any other mutation. The other cohort is the BRCA 1 and 2 or ATM mutations. Let us look at, so within this PROFOUND trial only we have two cohorts, but that may not be very relevant at this point. We will look at the results of this PROFOUND trial. We saw that it gave an advantage of roughly about improved and PFS, progression-free survival of about 6 months. And the risk of progression was reduced or the death was reduced by about 66% in the olaparib arm. And but then looking at the overall survival, it only added about 3 months in addition to the other therapies. This is a poor slide, but then if you see the adverse events are far and few, anemia being the most common and nausea being the second most common, which are all fairly manageable. Okay, so olaparib has actually been proven in a phase 3 randomized trial as being advantageous, giving about 3 months in addition in overall survival and gives a 6 months PFS. But if you were, these are the MEDONC terms. But if you are carefully looking at it, 66% of patients who went on that arm actually had a better progression-free survival than the standard arm. Okay, this has again been tried along with other drugs. The only trial that is as yet been published is with abiraterone in combination. These are all phase 2 trials, so we don't have clear data if we can actually combine it with the other molecules at this point. If if the radiation oncologists are quite curious to see if it has already been combinedly used with along with radiation, no, it's only been tried in melanoma setting and not in prostate setting as yet. Okay, so we should also be knowing that these trials have actually looked at certain biomarkers and the response also. So both PROfound and the TOPAR trial have actually seen biomarkers for response, and they noticed that those who had BRCA1 and 2 and the PALB2 mutations had good clinical response and objective response rates. So the ones that had ATM and CDK12 mutations did not have. So was the finding in PROfound trial also. BRCA and ATM had fairly good response, where BRCA1 and 2 had actually good response. And ATM was also showing response because it was clubbed in that cohort A. But we should see that as a conclusion, the authors mentioned that those with AT mutations still did not do that great. So even if you had HRR mutations on a patient with CRPC, only certain mutations still show some sort of response. So let me conclude with whatever has been discussed till now. Prostate cancer is one of those first diseases where overall survival has actually been improved using a PARP inhibitor, which can either be olaparib or rucaparib. Up until now, similar to the ovarian cancer, somatic or germline BRCA1 and 2 mutations are the ones that seem to be the most predictive biomarkers showing efficiency of PARP-I inhibitors. Now, see, it is left to the audience to take this conclusion. You might find a CRPC person who has gone through 1 or 2 lines of treatment with non-hormonal agents, and those should be harboring HRR mutations, which is about 27% chance, of which if you're going to find only BRCA1 and 2, the chance is going to be about 13 to 18% only. And those will have additional 3 months of overall survival with PARP inhibitors. That is the conclusion. Thank you so much for this opportunity. I'll be happy to take questions.